patient with Graves' disease exhibits exotomos and periorbital edema. Explain the changes of this optomopathy in Graves' disease. So Graves' disease is a condition where the body start producing these antibodies, thyroid stimulating immunoglobulins. These stimulate the thyroid gland and then it starts to enlarge. Okay, that's what causes the goiter. But then these same TSI, okay, it has the same structure as TSH, so they basically just bind on the same receptors, and then it so happened that the eyes, okay, the orbital tissues, the eye tissues, especially at the back, okay, they are activated. Okay, they are activated as a result of these TSH receptor antibodies. So what happens, they start producing glycosaminoglycans, which leads to swelling behind the eye. And what happens, this pushes the eyeball outwards, okay, causing this condition, protrusion of the eyeballs. This is what is called exotomos, okay, periorbital edema. So there is edema taking place behind the eyeballs, pushing it outward. So this is seen, a clinical sign that is seen in a patient with Graves' disease. A patient treated with radioactive iodine therapy for Graves' disease later develops hypothyroidism. Okay, so this patient was treated for this was the treatment that was used for treating Graves' disease. Now there is a catch to this treatment. There is a risk, and the risk is that if you treat a patient with radioactive iodine therapy, it ends up destroying the thyroid gland, okay, the cells of the thyroid gland, and the person, in as much as you'd have treated Graves' disease, the person won't be able to produce T3 and T4, so you have to put them on a lifelong medication. You need to supply them with a long life levothyroxine, which is just a synthetic T4, because these hormones in Graves' disease, they are simply just too high and they are causing problems. So if you treat them with this, they will reduce, but the thyroid gland will not be able to produce these hormones. Okay, so radioactive, it ablates the thyroid tissues, it destroys the thyroid tissues, so the person would have to be on lifelong levothyroxine. Okay, a 25-year-old man presents with weight loss, tremors, nervousness, wide eye stare. Describe the metabolic, neuromuscular, and emotional effects of thyroid toxicosis in Graves' disease. So the metabolic effects is that, number one, okay, this patient, since they would high T3 and high T4, to mean that if they have high metabolism, okay. On the neuromuscular, there is excitement and contractibility. Okay, so this is what is causing the tremors. The muscles are contracting at high speed. The nervousness also, the neural cells will also be excited. Okay, so it actually works on the sympathetic nervous system. So the sympathetic nervous system can excite the nerves and the muscles, causing tremors and nervousness. High metabolic rate will result in weight loss, and also because there is high metabolic rate, the person also will lose an appetite. Okay. Emotional effects. The people that have got high levels of T3 and T4, they are very irritable. Okay, very sensitive people. Okay, they usually have insomnia, they fail to sleep. Okay, so these are just on the emotional effects, but I listed them here. Okay, they are all here. So anxiety, irritability, insomnia, restlessness. Okay, everything I listed it there. A patient with Graves' disease undergoes thyroid uptake scan, interpret the expected findings on the radioactive iodine uptake and the diagnostic. So if a person has got Graves' disease, the rate at which they uptake iodine is very fast because the gland is actually big, so there's diffused increased uptake of radioactive iodine therapy. Okay, so there is an increased uptake. Okay, so this is what is used to distinguish Graves' disease from other thyrotoxicoses. Okay, so that's what happens here. So there's just an increased uptake. Okay. Okay, a 48-year-old man presents the signs of acromegaly, increased heart and shoe size, cause facial features, macroglossial, enlarged hands. Lab results show elevated IGF-1 and the lack of GH suppression. What is the primary stimulus? What is the primary physiological stimulus for growth hormone? So the primary, let's see, are these the questions we're supposed to do? Let's see again. Okay. I think these ones, they're up here. Okay, question 7 going down. Yeah. Okay. So explain how excess growth hormone leads to clinical features. So this is acromegaly. So now we're talking about growth hormone. It will lead to the features. So the man is 48 years old. So meaning he's past the stage of growing tall. Now having too much growth hormone at this age won't cause giantism, instead to cause acromegaly. So it will lead to soft tissue overgrowth. Okay, there will be an enlarged tongue, macroglossia, enlarged hands and feet, bone overgrowth, okay, especially in the jaws, the frontal bones and extremities. The skin will appear more thick and some facial features. Okay, so these changes are occurring because growth hormone simply leads to the secretion of IGF-1. This is what does most of the function. Okay, then 8. How does growth hormone exert its growth promoting effect? So growth hormone will exert its growth promoting effect simply because it leads to production of this from the liver. So once growth hormone is released, it acts on the liver, causing the liver to secrete IGF-1, and IGF-1 so it stimulates it. Once it is produced, it then acts on the bones, the muscles and other organs to promote cell growth, protein synthesis and proliferation, all these leading to growth. So IGF-1 is the main mediator, okay, of growth hormone anabolic and promoting effects. Why does growth hormone excess lead to insulin resistance? Okay, now we need to first know, what does insulin do? So insulin, its main job is to lower blood glucose, okay, but then growth hormone comes in and increases blood glucose. Most of the functions growth hormone does, they increase glucose. So it is referred to as an anti-insulin in nature. It promotes lipolysis. Lipolysis is a breakdown of fats which are converted to acetyl-CoA, and that acetyl-CoA can be converted to glucose. So that's what growth hormone does. It also leads to gluconeogenesis, which is the formation of glucose. It keeps glucose in the blood by reducing the uptake of glucose in the muscles and fat. Okay, so all this causes hyperglycemia, and this can later lead to secondary diabetes mellitus because of the hyperglycemia, especially for people with acromegaly. What are the potential complications of untreated acromegaly? Okay, so if it's not treated acromegaly, meaning you are going to experience high levels of growth hormone, and high levels of growth hormone will lead to what? High levels of glucose, hyperglycemia. Okay, and so on the cardiovascular part, okay, growth hormone, it also facilitates, okay, it also facilitates, since its growth even of soft tissues, okay, and the muscles. The heart muscle can also increase in size, causing cardiomyopathy, okay, and also meaning the pulse of the heart will change. That will cause arrhythmias due to expansion of the heart, again that can cause heart failure, okay, and that will also lead to hypertension, because now the heart has changed the level at which it's pumping blood to increase the pressure of blood, eh? On the muscles and the skeletal system, what is affected most are the joint, because here a person has already grown, but then growth hormone is trying to force the bones expanding further, and growth in the bones occurs in the tissues, in the joints. So there will be joint pain because the bones are expanding in size when the epiphyseal plates are already closed, right? So that will cause joint pain, okay, arthropathy, okay, even the bones that are keeping the spinal cord, those vertebral bones, also they will increase in size, and this can cause problems on the spine. So you find a lot of people that have this condition, acromegaly, they have a bumpy here on the shoulder, behind here, or like the spinal cord bends like this, because it's trying to grow more than it has already grown. Also they suffer from carpal tunnel syndrome. On the metabolic, we've already said it has insulin resistance properties leading to diabetes, and then also you can see risk of colon polyps because of overgrowth in the colon. Also sleep apnea because of the enlarged tongue. Sleep apnea simply means difficulties in breathing when somebody is sleeping, because probably the tongue is too large and it's blocking the airway. Okay, how would you differentiate giantism and acromegaly? So both conditions, it's increased growth hormone. Giantism, it occurs in children. If the child has an increased growth hormone, they'll become a giant. But if it's in a child, in an adult, that's when it leads to acromegaly. So the only difference, this takes place in a child, this takes place in an adult, and they have this will lead to giantism, this will lead to acromegaly. So giantism occurs before the epiphyseal plates are closed in children, okay, leading to linear growth. This one won't lead to linear growth. It will just lead to growth in soft tissues and thickening of bones, and not height necessarily, okay, because a person is already grown, they can't grow any taller. What is the most likely cause of this patient condition without imaging? So for acromegaly, the most likely, what would actually cause growth hormone to increase in an adult? It's when there is a tumor in the pituitary gland. The pituitary gland is what produces growth hormone. So if there's a tumor, that tumor will produce excess growth hormone. So the imaging study to confirm the condition, you do an MRI, okay, and it can identify even the size and location of the tumor in the pituitary gland. Discuss the treatment options available for growth hormone excess. The first line of treatment, actually, since it's a tumor, you can do surgery as the first line. You can cut off, though you can also use, since you want to lower growth hormone, you can use certain medications that have been made, okay. You have these medications made from somatostatin, okay, and also these other medication can be used to lower levels of growth hormone. Radiotherapy, if medication and surgery fails, but this one, like we said, it has got some risks, okay, especially if it's iodine therapy. Okay, I think we did the multiple choice questions. This is where we should have ended.